This ECG belongs to a 45-year-old female who presented to the ER with palpitation and uneasiness. She had no known comorbid condition and was otherwise healthy. She reported a similar episode 2 years ago that had resolved spontaneously. However, this time the symptoms persisted for more than 6 hours, prompting her to seek medical care. On arrival, her blood pressure and saturations were within normal limits. The ECG demonstrated a regular narrow complex tachycardia without identifiable P waves. Vagal maneuvers are attempted initially, followed by 6 mg of intravenous adenosine without any effect. After administration of 12 mg of adenosine, she reverted to sinus rhythm. This represents a classical clinical presentation of AV nodal reentry tachycardia. AVNRT is the most common form of paroxysmal supraventricular tachycardia. It typically presents between second and fourth decade of life, and it is more common in females. Most patients lack any structural heart disease or comorbid conditions, and the episodes are usually paroxysmal and revert spontaneously to sinus rhythm. They are often triggered abruptly by autonomic shifts such as increased sympathetic tone or reduced vagal tone during a physical or emotional stress. In an otherwise healthy individual, AVNRT is not a life-threatening arrhythmia, although rapid rates may provoke angina, pulmonary edema, or hypotension in older patients or those with limited cardiovascular reserve. AVNRT is a micro-reentry tachycardia that requires dual conduction pathways within and around AV node. Understanding AVNRT requires a familiarity with the conduction system's anatomy and electrophysiology. This is the schematic diagram of opened right atrium. Impulses originating from the SA node reaches the AV node via internodal pathways. Recent studies have redefined the traditional concept of internodal pathways. They are not insulated specialized tracts like a His bundle or a Purkinje system. Rather, they are organized stacks of atrial myocytes that function as a preferential conduction routes between the nodes. Three principal pathways have been defined, which connects the SA node and AV node. The anterior route, which is short and direct, supplying the anterior septum and the AV node, called the Bachmann pathway, which also supplies the left atrium. The middle route, passing via the limbus of the fossa ovalis and also converges anteriorly, called as the Wenckebach pathway. The third pathway is the posterior route, which is longer, looping via the crista terminalis and the eustachian ridge to the coronary sinus musculature, called as the thoral pathway. Multiple human studies support a short, fast anterior conduction route and a longer and slower posterior route. The anterior pathways tends to reach the AV node earlier, whereas the posterior route conducts more slowly, especially in a remodeled or dilated atria. The AV node itself consists of several structural components: the compact node, the superior and the inferior extension. The inferior extension is again divided into right inferior extension and the left inferior extension. The central fibrinous body provides the insulation. Histologically, three distinct cell types with different electrophysiological properties are found in AV node. The compact node contains the nodal cell that generate the calcium-dependent slow type action potential that produces the characteristic nodal delay. The transitional cell, atrio-nodal and the nodal His bundle form the interface between the compact node and its input and outputs. The dual pathway physiology exists at two levels. First, among the internodal approaches, that there is an anterior route which conducts rapidly and a posterior route which conducts slowly. Second, within the AV node itself, the conduction is characterized by differential velocities and refractory periods. The inferior extensions form the substrates for the slow pathway with short refractory periods, whereas the compact node and the superior extension represents the fast pathway with longer refractory periods. During a normal sinus speed, the impulses arrive at the AV node via the fast anterior internodal pathway and engages the superior extension and the fast intranodal fibers of the AV node. The slower posterior impulses arrive lately through the slower pathway, entering the node when most of the AV node and the His bundle system has already been activated. This renders the slow pathway impulse redundant, while both impulses converging and terminating within the node, while the His bundle conducts to the ventricles. In AVNRT, the dual nodal physiology alone is insufficient. A premature atrial complex arriving at a critical window of differential refractoriness is required. A premature atrial complex often encounter a refractory fast pathway because of its longer refractory period, but find the slow pathway excitable due to its short refractory period. So the conduction proceeds anterograde through the slow pathway, but by the time the impulse reaches the compact node, the fast pathway has recovered, permitting a retrograde conduction back to the atria through the fast pathway. The His bundle is also activated in parallel. The retrograde fast pathway activation exits through the superior extension into the atrial musculature and eventually returning via the septum and the coronary sinus musculature to the inferior extension, forming a micro-reentrant circuit. The usual result of a premature atrial complex encountering a dual pathway physiology is a solitary atrial echo beat, after which the sinus rhythm resumes. Reentry does not always perpetuate into a sustained AVNRT. Atrial echo beats are common even during exercise in a healthy individuals. Sustained AVNRT not only required a timed premature atrial complex but also require an excitable gap. That is, the action potential wavefront must continuously encounter excitable tissues to propagate. Excitable gap appears when the total circuit length exceeds the wavelength. The wavelength is given by lambda, which is equal to conduction velocity into refractory period. In short, a sufficiently slow conduction velocity down the slow pathway and appropriate recovery of the fast pathway essential to permit the retrograde conduction. If these conditions fail, the reentrant attempt terminates after a single loop. This explains why the dual node physiology is frequently found in electrophysiology of healthy individual, but the sustained AVNRT is rare. Sustained AVNRT requires appropriately timed premature atrial complex with circuit characteristics influenced by anatomical variation and autonomic inputs. In ECG, AVNRT presents as regular narrow complex tachycardia, typically around 140 to 220 beats per minute. Because atrial and ventricular activation occur nearly simultaneously, P wave may be absent or embedded within the QRS complex or visible as pseudo R dash in V1 or pseudo S wave in the inferior leads. Retrograde atrial activation via the fast pathway produces a short RP interval. In atypical variants called as fast slow AVNRT, the retrograde activation of atrium occurs via the slow pathways, generating a long RP interval tachycardia. In such cases, the P waves are embedded in the ST segment or in the early T wave, forming the PT complexes. Management depends upon the hemodynamic stability. Unstable patients require synchronized DC cardioversion. The stable patients are treated exploiting the arrhythmia's dependence on the AV nodal conduction. Vagal maneuver, intravenous adenosine are tried. If they are not effective, then we go for beta blockers and non-DHP calcium channel blockers. Long-term management determined by the symptom burden and the patient preference. Options include long-term suppressive pharmacotherapy like a beta blocker or calcium channel blocker prophylaxis or catheter ablation for a definitive cure. Catheter ablation targets the slow pathway region in the inferior nodal extension and it spares the compact node. So this strategy achieves about 95% success rate with less than 1% risk of AV block because the normal beats preferentially travels through the fast pathways. The risk of AV block is rare. In summary, internodal conduction architecture delivers impulses with different arrival times. Under normal conditions, slow pathway impulse is redundant. Dual conduction physiology within the AV node permits the re-entry. Though PACs act as triggers under autonomic imbalance, the maintenance of AVNRT is determined by the circuit properties. AV nodal blockade via vagal stimulation or pharmacological agents terminates AVNRT. Ablation of slow pathway eliminates the substrates without compromising the global conduction. Thank you.